And I am going to introduce both of our speakers before giving them the floor. Okay, so William M. Geisler, MD, MPH, excuse me, is a professor of medicine and epidemiology in the Division of Infectious Diseases at the University of Alabama at Birmingham, UAB. He is an internationally recognized expert on chlamydia and Mycoplasma genitalium infections, conducting epidemiological, clinical, and basic science research on these infections. He has over 20 years of clinical experience in the evaluation and management of sexually transmitted infections and provides STI education and training through the Southeast STD HIV Prevention Training Center. He is on the editorial board of Sexually Transmitted Diseases and has served as an STI expert consultant for CDC and WHO. He is also director of the UAB STD program and the research director of the UAB Diagnostics Mycoplasma Laboratory. Very excited to have him here today. And then I'll go ahead and introduce Dr. Munson. Eric Munson, PhD, DABMM, is Associate Professor and Chair of the Department of Medical Laboratory Science at the Marquette University in Milwaukee, Wisconsin. Dr. Munson completed his undergraduate studies at the University of Wisconsin, Green Bay. His graduate work at the University of Wisconsin and the postdoctoral fellowships at the Wisconsin State Laboratory of Hygiene and the University of Iowa Hospitals and Clinics. He served as technical director of a system-wide microbiology laboratory for 15 years prior to moving to Marquette. Munson served as editor of Journal of Clinical Microbiology for 10 years and as chair of the CLSI M64 Document Development Committee. He currently serves as chair of revision efforts relative to the CLSI M35 document and is a member of the Wisconsin Clinical Laboratory Network Technical Advisory Group. Very excited to have Dr. Munson here today. So I will go ahead and stop sharing and I will let our wonderful speakers have the floor.
There we go. All right. Sorry, one more time. Can you see my slides okay?
Yes, we can see them. Thank you.
Okay, great. All right. So thank you for the introduction, Kate, and I want to welcome everyone. Thank you for attending our webinar today. And I'm going to be the first speaker before turning it over later to Dr. Munson. I want to just briefly highlight the disclosures for both myself and Dr. Munson listed here. So as was listed on the webinar announcement, we're going to talk about the key clinical manifestations of Mycoplasma genitalium, and I'll cover that. Then I'll be turning it over to my co-presenter here, Dr. Munson, who's going to talk about epidemiology and resistance concerns with Mycoplasma genitalium, as well as reviewing Mycoplasma genitalium diagnostic approaches and testing recommendations. And then it's going to be turned back over to me to kind of wrap it up, talking about how do we manage M. genitalium infection, and I'm going to present some cases to kind of illustrate that. So let's start first talking about clinical manifestations. For those who, first of all, are not aware of this bacteria, Mycoplasma genitalium, we've known about it now for basically about 40 years. But it really wasn't until the last 10 to 15 years where we started to develop better diagnostics to understand more about the clinical significance and epidemiology of this pathogen. So in regards to clinical significance, the easiest way to think about the clinical significance of M. genitalium is to think about chlamydia. Even though they're quite different bacteria, their clinical presentations are quite similar. So as you see with chlamydia, Mycoplasma genitalium can cause urethritis in men and also in women. The symptoms include painful urination and urethral discharge. And in the case of men, when we do an exam, we'll see some meatal redness. So that's redness around the opening of the urethra. And we may see urethral discharge as shown in the representative photo there in the top right. So in our clinic, when we have symptomatic men, we would do a urethral gram stain on them. And often with M. genitalium, we're going to see, 2 or more white cells per high power field. That bottom image is a gram stain showing you about 15 or so white cells on that field. And then the only other thing I want to point out about the M. genitalium presentation with urethritis is that when we see men with recurrent persistent urethritis, Mycoplasma genitalium now is the most common cause of that. And I also want to just mention briefly that in women, that sometimes women with Mycoplasma genitalium urethritis are misdiagnosed as a urinary tract infection based on their symptoms. All they do is get a urine dipstick done, and then they're given Bactrim or some other antibiotic to treat a UTI. So always think about an STI like M. genitalium in women with UTI-like symptoms who are sexually active and at risk for STIs. And then, so you would want to do the testing on those women. In women, cervicitis is a common presentation of Mycoplasma genitalium, and the symptoms, they're quite nonspecific, but they include vaginal discharge, painful sex, and/or irregular bleeding. And so when you do an exam on a woman with Mycoplasma genitalium who has cervicitis, you may see findings like as shown in the top right photo, cervical discharge, and you may also see findings when you insert a swab into the cervix to collect a specimen for testing. They may start oozing blood, which we call that easily induced endocervical bleeding or friability, as shown on the bottom right. And just like with urethritis in the case of cervicitis, Mycoplasma genitalium is one of the most common causes of recurrent persistent cervicitis, and of course, urethritis. Now, there are several other possible clinical manifestations of Mycoplasma genitalium in both men and women. And I'd like to first point out that in both men and women, arguably the most common clinical presentation of Mycoplasma genitalium infection is an asymptomatic infection. And so we're a little bit biased in our studies that are done in clinic settings because people are more likely to come to clinic setting when they have symptoms or signs of infection. But larger studies, more done in community-based settings, suggest that the majority of Mycoplasma genitalium is actually asymptomatic. But in men, in addition to urethritis as a clinical presentation, rarely we might see epididymitis, and there's also studies associating proctitis with M. genitalium in men who practice insertive anal sex. In the case of women, I already mentioned earlier that vaginal discharge can be a presentation of M. genitalium in women. And then M. genitalium is also associated with pelvic inflammatory disease, infertility, and perinatal complications, particularly preterm birth. When I say associated, it doesn't mean that it's causal and that we know for sure M. genitalium causes things like PID, infertility, and perinatal complications. It's just that there is some limited evidence to suggest that it might cause those clinical presentations. So that was just a kind of brief overview of clinical presentations. I'm going to turn it over to my colleague now, Dr. Munson. I'm going to stop sharing my screen so he can start sharing his. He's going to talk about epidemiology, the clinical tests, or the tests that we would use for diagnosing M. genitalium, and then also what the testing recommendations are before turning it back over to me to talk about treatment. And the floor is yours, Dr. Munson.
Thank you very much. Kate, can you confirm that my slides are showing up and my voice is showing up as well?
Yep,
All right,
we can see and we can hear you.
All right, thank you very much. Appreciate the opportunity to speak to everybody today. And I see a lot of people from Wisconsin in the chat room, so go Wisconsin and all that good stuff. So we're going to sort of set this up by starting close to home and then maybe expanding our knowledge of this STI a little bit more nationwide. So to set up the story, I'm obviously from Wisconsin, as was introduced and as I just told you. And make sure I'm advancing the slides. And in Milwaukee, not only are we famous for beer, the racing sausages, and overall Gemütlichkeit, we're also infamous or famous for a lot of STDs, namely chlamydia and gonorrhea. And as evidence of that, the CDC for a while in the past put out annual publications of rankings of sexually transmitted infections in a metropolitan setting. And this review is sort of a 10-year summary of rankings in major metropolitan communities. And Dr. Geisler's Birmingham is in there, of course, and several other areas. And typically, Milwaukee metropolitan area has ranked either in the top 5 or even number 2 as far as chlamydia detection rates per 100,000 population. And again, these are data in a metropolitan area, far above the national average. And if you look at the gonorrhea rates, we're pretty much number 2 in that facet as well. So the reason I point this out is that we are in a high prevalence STI community that, in my opinion, allows us excellent opportunities to evaluate new and emerging diagnostic assays. And our laboratory has been fortunate enough to have done that in a number of contexts in the past. All right, so perhaps our first quote-unquote exposure, for lack of a better word, to Mycoplasma genitalium was a local STI clinic director, Dr. Greminger, who approached me and asked, ever since we started doing your trick test, I'm going to move my screen a little bit so I can read this here. Your new trick test, and by the way, we evaluated a trichomonas molecular test for use in that community, in the MSN community at that time. We still notice guys with obvious urethritis, but they have negative tests for chlamydia, gonorrhea, and trick. I really think this is mycoplasma. Can you test for this? So this was circa 2010 when, a lot of our M.gen diagnostic assays were reliant on, say, serology or even culture, if laboratories such as the specialized one that Dr. Geisler runs has that capability available to providers. But, a lot of local labs outside of Birmingham or Seattle, Washington, did really not have a strong capability of doing that. So M.gen was largely going underdiagnosed and even untested, not assessed. So we had access to a commercially available analyte-specific reagent at the time, which later became FDA cleared for molecular detection of Mycoplasma genitalium. And this was a study of about 2,000 male urines local to Milwaukee, and detection rates are given here. If you think we have a lot of chlamydia, we have just as much M. genitalium in the male population. This is about 2,000 first void urines. When looking at some of the individuals or some of the demographics involved in the study, there was a significant number of gentlemen involved in this study that were part of a local STI clinic. And for that reason, we had access to some of the demographic information as well as the symptomatic or asymptomatic nature of these individuals. So when looking at the individuals who were only positive for M. genitalium, no co-infection with chlamydia, no co-infection with Neisseria gonorrhoeae, we noticed that about 40% of them had homosexual preference or practices, about 60% 60 to 67% heterosexual practices, a large median and mean value of sexual partners, and about 3/5 of them were symptomatic for urogenital disease at the time of specimen collection. And this ranged from discharge, I guess, analogous to what Dr. Geisler showed on that one slide, in addition to dysuria and burning and tingling. But what was also interesting about that study of first void urine, those urines were also assessed for Trichomonas vaginalis in an off-label type of setting, as well as chlamydia and gonorrhea. All three methods by molecular amplification methods. What you see here on the left is STI profile. So anybody positive for any of the 4 STIs, the permutations of detection were indicated here. And then the numbers that you see here are not detection rates, but they're what proportion of STI clinics had that profile, or what proportion of outpatient individuals, men, had that profile. So again, these are not STI detection rates. And what was found appeared to be a sort of a dichotomy between Mycoplasma genitalium infection in these first void urines versus a Trichomonas vaginalis detection in these first void urines. It seems that the folks at the STI clinic, the male urines that came from the STI clinic, had a greater preponderance to be M.gen positive versus male urines from more of an outpatient, maybe not an MSM population, having more of a Trichomonas vaginalis detection rate. So this chart will sort of set us up for a couple of topics I'll discuss later in my time allotted. So that's M.gen in male population. I'll probably talk about 3 other demographics locally within the time that allotted. The second one will be females. So we had the opportunity to assess this molecular amplification test for M.gen in female populations. And again, this is sort of a point prevalence study. How much M.gen is there out there in the female population? And again, if Milwaukee has a lot of chlamydia, they have way more trick than chlamydia, statistically speaking, and statistically more M.gen than either of the other 2 that I mentioned. When you start to look at this from a demographic standpoint, a couple of interesting things came about. Number one, looking at source location or source facilities where these specimens came from. And by the way, we looked at vaginals, cervical swabs, as well as first void urines in this study. And it seemed that the overall highest detection rate seemed to come in an emergency room urgent care population. I'll show you some nationwide wide data in a little bit that will support that notion that there is quite a bit of M.gen in individuals presenting for emergency care. Perhaps that's their only primary care provider in some situations. The other thing of interest that I thought from this table is that look at the sole detection rate of any female who was positive for any STI in this study, in a point prevalence study. Of all the people positive for any STI, M.gen was the only one detected in 72% of these individuals, suggesting, especially in symptomatic patients, if you're not looking for M.gen in the first place, even in the context of a recurrent cervicitis or something like that, there's a good possibility that you're going to miss laboratory diagnosis of an STI. And again, I think a lot of providers are not necessarily knowledgeable on the fact that there are better testing methods available. And again, this advent has come in just the last 5 to 10 years. So perhaps that might be something that folks may want to consider as far as education and communication. So here's the nationwide study that I promised. This is done by Dr. Manhart et al. And this was an assessment of both females and males, very large number, about over 3,000 in multiple sites in multiple regions of the country. They came up with about a 10% prevalence rate of M.gen infection. In that previous slide that I showed you around Milwaukee, that detection rate was about 11%. So that was pretty much on par with the nationwide information. They got into a lot more demographics associated with M.gen detection. So for instance, there was an odds ratio of 1.88 in African-American females versus Caucasian females. So as Dr. Manhart would like to say, there's a 188% greater rate in African-American females than in Caucasian females. And you get the idea of in male gender as well. So looking at some of the demographics, and Dr. Geisler mentioned before that a lot of M.gen is quite similar to chlamydia. And as far as age range is concerned in this study, again, they were seeing a lot more M.gen in the younger population, anywhere from 15 to 25 or 34. And that was also true in the male gender. Again, similar to what we see with chlamydia infection and gonorrhea infection. They did some initial assessments on a regional basis. Some of the numbers were limited by small n values, such as the Northwest right here, but not really much of a significant difference as far as certain regions of the country, pretty well spread out. And even with some of the male data, some of these odd ratios a little bit up, but for the most part, relatively similar rates. Then as far as source facility or patient location, again, there was significant percentage and significant odds ratios in that emergency medicine or ER type of setting, analogous to what I presented with some of our local data. All right, then they had the ability to look at symptomatic status on a much broader range than what has previously been published. And overall, and the table that I'm showing here is patient-reported symptoms. Some of the data that we will get into down here is more of a clinical diagnosis or a clinician diagnosis. I'll get to that in a little bit. But from a patient-reported symptomatic standpoint, any reported symptom had a significant odds ratio associated with M. genitalium infection, and that was true to a lesser extent in male populations. From a clinician standpoint, the presence of M. genitalium, there was a 2.97 odds ratio for the detection of M. genitalium in cases of urethritis, also significant odds ratios in the context of vaginitis and cervicitis. And then finally, when reading the discussion section of this paper, it's important to note that there were actually very few clinical or symptomatic characteristics that, well, few characteristics that really distinguish asymptomatic from symptomatic M. genitalium infection. So, that suggests to me, to some extent, the necessity for accurate testing for this organism. Now, when we get into the diagnostic considerations, there's going to be a fine line drawn between symptomatic and asymptomatic. And I think Dr. Geisler is probably going to elaborate on that further when he presents his cases at the end of the seminar. So getting into diagnostic considerations, a lot of these are pilfered from the CDC's STI treatment guidelines that were published in 2021, so about 3 years ago. To my knowledge, to date, there are 3 FDA-approved molecular assays for M. genitalium detection from primary clinical specimens. And those include products that are manufactured by Roche, manufactured by Abbott, and manufactured by Hologic. And again, I'm not here to espouse anyone in particular. I'm just here to say that there are 3 FDA-cleared assays for this. And the clinical indications or the specimen indications may vary depending on the kit. So please read your package insert with respect to that. Okay, getting further into the CDC guidelines as far as whom should be tested, right? So the CDC guidelines at current state note that females with recurrent cervicitis and males with recurrent non-gonococcal urethritis should be tested. Now, if testing's not available to you, then an M. genitalium diagnosis should be suspected in that population if testing is not available to a provider. Pelvic inflammatory disease should be considered, or M.gen should be considered as a potential etiology of pelvic inflammatory disease. At current time, what is not recommended for routine screening are asymptomatic individuals in both genders, right? And note that the data that I presented previously is sort of a point prevalence population assessment, and also extragenital testing, such as pharyngeal swabs or rectal swabs, are currently not recommended at this time point. What I will present next are some data regarding a third demographic that we've actually looked at with respect to M. genitalium, and that's the MSM population. And looking at some of these data may bring forth perhaps public health concerns that might factor into decisions made to test on an off-label basis. So let's go to a cohort that's based out of Chicago. This is known as the RADAR cohort. And this is run by a clinical psychologist whose goal is really to assess behavioral patterns within the MSM population, with an ultimate goal of trying to keep these folks free of HIV infection. So how do behavioral or social factors fit into trying to remain HIV seronegative? And they sort of use STI screening as sort of an endpoint to monitor how their educational efforts are working in this MSM cohort. So in past studies, our group has collaborated with them and looked for the detection of 4 STI agents, either in urine or rectal swab specimens in this cohort. This is done on a longitudinal basis. Now, up to maybe 3 to 5 years ago, rectal swab testing was not FDA indicated for a variety of commercial manufacturers. I guess I'm happy to say that at least 2 manufacturers now have rectal swab indications for chlamydia and gonorrhea screen. Please keep in mind that most commercial manufacturers do not have an FDA indication for rectal swab screen. So this was all done as a laboratory developed test with extensive validation. So in essence, there is a tremendous prevalence of M. genitalium in rectal swabs in this MSM cohort. When you look at the potential benefit of doing M. genitalium screening in this cohort, what I want you to focus in on is this red bar. This is essentially the number of participants in the cohort that screen negative for any of these 4 STIs. Now, the first presentation of this chart at the time was using only FDA indicated specimen sources, such as urine for chlamydia and urine for gonorrhea. So based on just FDA indications, we have a substantial number of individuals who are overall negative for STI. When you add laboratory validation at the time of extragenital sites, by the way, these are now FDA cleared or indicated on some kits, we see that number of negative patients go down tremendously. But when you add M.gen, especially the rectal specimens, you really pick up a number of individuals who are carrying agents of STI in that anatomic site. But again, please note that routine screening of rectal swabs is not recommended by the CDC at this time. So why might this be important? The importance of this is that, look, it may indicate something about the potential risk factors or other co-infections with STIs. So I'm going to show you 2 slides that are sort of constructed in the same way. At time of rectal swab collection, patients were also filling out self-questionnaires, so self-questionnaires as far as behavioral factors, risky sexual behavior, and so forth. So when you look at these numbers here, when looking at, for example, the parameter of condomless insertive anal or vaginal sex, those who report that behavior had a rectal M.gen detection rate of 23%. Those who did not report that behavior had an M.gen detection rate of about 20.5%. So on a behavioral standpoint, there's really no significant difference between presence of M.gen and lack of presence or absence of M.gen. But when you look at other factors such as race or ethnicity, there was a much higher rectal detection rate of M.gen in African American populations versus Caucasian or Latino Hispanic. But probably the biggest one here, as far as I'm concerned, is HIV seropositivity. So rectal M.gen detection rates were 42% in HIV seropositive individuals and far statistically less in seronegative individuals, suggesting a potential role, not necessarily a link, maybe a role or a possible association in M.gen rectal detection and concomitant HIV infection. And again, that's something that needs to be studied in more detail. Now, this was a longitudinal cohort, and this cohort had the ability to monitor M.gen prevalence over 6-month time periods. And here's sort of a capsulization of some of these data. So in individuals who were positive for N-gon or Neisseria gonorrhea at baseline, and by the way, these were all rectal swab screenings, those who were positive at baseline were 5 times more likely to be positive at the 6-month checkup than those who were negative at baseline. So you see how these odds ratios were up over a 3-year period. Those numbers were statistically higher for M.gen, meaning that if a person has a rectal swab positive with M.gen at initial screening, they're 12 times more likely to also have it at a 6-month, 5 times more likely at an 18-month, and so on. And these data were statistically significant over that of Neisseria gonorrhea. Looking at this from the other aspect, likelihood to remain negative. So this is called a survival estimate percentage. So individuals who were negative for Neisseria gonorrhea in rectal swab specimens had a 95% likelihood of being negative at the next 6-month follow-up. But what you notice for M.gen is that there's a lesser likelihood of remaining negative for M.gen in a rectal swab, which suggests to me that perhaps N. genitalium might be a transient, quote unquote, colonizer in that anatomic site. And if you're looking at that aspect in the realm of potential association with HIV, that transient colonization or that transient prevalence, so to say, could play a factor in potential HIV transmission in that high-risk demographic. So one more demographic to look at, I'm watching the time, I'll be done pretty quickly, is the university population. So we do university screening here at Marquette for agents of STI. Here are our detection rates up here. M.gen is right up there with chlamydia trachomatis. We do have access to symptomatic versus asymptomatic information, greater detection rates in symptomatic individuals, except for Mycoplasma genitalium in females. That difference between 7% and 6% was not statistically significant. Again, suggesting that there's a lot of M.gen and asymptomatic individuals who may or may not be tested. And of course, there's no CDC guidelines for asymptomatic testing at this time. To further extend this a little bit, I will just summarize this slide by saying that the prevalence rates for M.gen are actually lower than incidence rates. That is not true for chlamydia, which suggests to me that we have frequent flyers to our screening program that can spit off multiple M.gen positive results. So when we looked at that on an audit basis, there's several more participants or a substantial number of participants who have screened positive for M.gen on more than one occasion, right? Suggesting that perhaps there's not a means or a mechanism to effectively perhaps treat these individuals, which suggests that there could be an issue with antibiotic resistance within our university M.gen population. So we had a student look at this a couple of summers ago, and using sort of a metric of follow-up negative molecular testing, it turns out that certain therapeutic regimens for M.gen were not very good in clearing M.gen from a patient's specimen at compound follow-up. And again, if they're not clearing M.gen, perhaps that could portend antimicrobial resistance. And when we looked at therapeutic options, it seemed like there were a fewer or a lesser percent of nucleic acid clearance with azithromycin regimens versus, say, moxifloxacin. So it seems like there's probably a lack of standardization in how the treatment was going, and it seems like there could be a potential issue with azithromycin therapy. So that leads me back to the CDC guidelines. People in the STI community were very excited because in the 2021 guidelines, M.gen actually got their own section versus being lumped into a common section dealing with urethritis. M.gen got its own section within the CDC guidelines. So we were pretty fired up about that. So Dr. Geisler will go into much more detail about the macrolide therapeutic implications. I'm only going to mention that the diagnostic strategies for M.gen now are incumbent upon whether or not you have access to a resistance testing assay. So Dr. Geisler is going to follow up on that. So unfortunately, even though there's guidelines that suggest that diagnosis should be a function of whether or not you have a resistance assay, there's no FDA cleared to date resistance assays, molecular assays in the United States. So that presents a problem. So there was a paper published in JCM last summer that sort of discusses a laboratory developed test on an automated instrument. Now, folks, there are research laboratories in Seattle and Birmingham that do this perhaps on a homebrew basis or a culture basis. This paper talks about a potential automated system in which you devise your own primers, devise your own assay, and run it on that. So this is actually a laboratory developed test. Had a limit of detection of about 180 copies per reaction, had a nice concordance rate with Sanger sequencing. So it seems like that if laboratories have the expertise and wherewithal to do something like this, this could be something that could be offered on a lab developed test basis. So getting back to resistance data in the United States, here's another study that Dr. Geisler was a co-author on. This was published in CID last summer, I believe. I think I have the wrong reference. This was actually from last summer. I apologize for that. So this is looking at over 1,000 specimens from 6 sites in 2020. I believe that coronavirus may have been involved to an extent in collecting all the data. There was about a 16% prevalence rate of M.gen. About 290 were collected for resistance testing. So this study kind of used the same assay that we talked about on the previous slide as a means of detecting macrolide resistance mutations in M.gen that could translate into clinical treatment failure. So resistance mutations were found at a prevalence rate of 3.5 per cervicitis, at about a prevalence rate of 1.8 for pelvic inflammatory disease and vaginitis. So a pretty high association with macrolide resistance and cervicitis, pelvic inflammatory disease, and vaginitis in this study. And again, I apologize for the wrong reference down here. They also had the ability to sort of stratify if there were certain parts of the country in which macrolide resistance was more prevalent, as indicated by these APR numbers right here. And from a probability standpoint, it seemed like at least one clinic in the southeast region of the United States may have had more of an issue with that. But again, there were certain parts of the country that weren't able to procure specimens. And again, I think this was largely done during coronavirus, which means that laboratories may have had other things to do versus supplying a lot of specimens at that point. So we've done a little bit of work in our laboratory. I'm going to skip this slide in the interest of time. We've actually looked at amount of M. genitalium or have titered M. genitalium in positive specimens. We've done this for about 1,500 specimens looking at the titer. So if you're into serology, this is like dilutions. What's the last dilution at which you see a significant result? So in general, female specimens have lower target burden of M. genitalium nucleic acid than male specimens. This was a statistically significant difference. And we also had the ability to stratify the amount of organism presence as a function of macrolide resistance detection. So it seemed as if the lower specimen titers had a lower rate of M.gen detection or M.gen resistance detection. So in general, in our study, female populations had a lower macrolide resistance rate than did male populations. And one last slide before I turn it back to Dr. Geisler. We stratified this by location of patient. So in general, our overall resistance rate was about 58%, which very closely mirrored the paper that of Dr. Manhart and Dr. Geisler. I think they had like a 59% nationwide resistance rate. But it looks like the resistance rate varied between community care, which tended to be a little bit lower, the MSM population, which tended to be a little bit higher, and even university populations such as ourselves, which seem to have a higher macrolide detection rate than did community care. So you see these detection rates, it seems like there were lower detection rates in lower titer specimens when there wasn't as much M.gen in them. And it seemed like the more M.gen you have in a specimen, the higher detection rate, although that's not completely a dichotomy. In my opinion, you still need to assess for M.gen resistance as indicated by the CDC guidelines. So I thank you for your attention, and I will stop sharing and I will mute and I'll send it back to Dr. Geisler for the remainder of the seminar.
Thank you, Dr. Monson. So I'll go ahead and for the next 10 to 12 minutes or so, kind of wrap up talking about the management of M. genitalium. And so, Dr. Monson highlighted, that there are different treatments for M. genitalium, and resistance is a concern for some of those, particularly the macrolides. And so the three drug classes we use in the US to treat M. genitalium are the tetracyclines, which includes doxycycline, the macrolides, which includes azithromycin, and then the fluoroquinolones, which includes moxifloxacin. He showed you briefly the CDC's recommendations for treating the initial episode of M. genitalium. And I'm showing you again just so we can go through this. And so doxycycline cures less than 40% of M. genitalium infections based off of clinical trials. So it's not very good. But it does still have a role in lowering the bacterial load of M. genitalium during treatment. So then if you come in with another treatment like a macrolide or a fluoroquinolone, you're less likely to develop resistance when you use that second treatment. And so the CDC recommends what's called resistance-guided sequential treatment, which is that you take somebody that clinically you suspect M. genitalium, such as a patient with urethritis, and then you treat them with doxycycline for the initial 7 days to lower the bacterial load. And then if you actually have access to resistance testing, if they're macrolide resistant, then you would go straight to giving them moxifloxacin for 7 days after the first week of doxy. If they do not have macrolide resistance, you would give them a 4-day regimen of azithromycin, 1 gram the first day, followed by 500 milligrams a day for the next 3 days. However, like Dr. Munson mentioned, there's no FDA-cleared M. genitalium resistance test available. Our lab at UAB actually does have a validated test that you can order if you send specimens to our lab, but a lot of people may not have access to that or means to actually do that. And so if you don't know if there's macrolide resistance with M. genitalium, based off the data that Dr. Munson showed you, that in general, over 50% of M. genitalium are going to be macrolide resistant, you would not want to use a macrolide for that second drug after doxy if you don't have resistance testing. You would want to go straight to moxifloxacin, because if you have a macrolide resistance mutation, then usually over 80% of people are going to fail treatment if you give them a macrolide. So for most people in the US who are treated for M. genitalium, they're going to get 7 days of doxy initially, followed by 7 days of moxifloxacin. Once you give this initial treatment, a couple other considerations. One is that, historically or traditionally, when we think about the public health management of partners of patients with STIs, we typically just go ahead and treat the partner as a contact. But M. genitalium is a little bit different. Number one, because the treatments are more expensive. Number two, the treatments may have more adverse effects. And three, the concordance rates of partners with M. genitalium is a little bit lower than what we see with some other STIs. And so what CDC recommends for partners is that if you have a partner of a patient with M. genitalium, instead of just treating the partner as a contact, actually test the partner first. And then if the partner tests positive for M. genitalium, then treat the partner for M. genitalium if they test positive. The other thing as far as management is that if a patient who's having signs or symptoms of M. genitalium, if they're clinically cured with resolutions of signs or symptoms, CDC does not recommend a test of cure. Now, I will say, even though CDC doesn't recommend it, people still often do it in clinical practice. If you are going to do it, and my own expert opinion, Dr. Munson can chime in at the end, I would wait at least 3 weeks minimum after treatment is finished before you do a test of cure, because if you do it less than 3 weeks, you run the risk of detecting kind of dead DNA or RNA from the bacteria that might be a false positive test. But it's not recommended, again, if patients are clinically cured. So I'm going to go through 2 clinical cases, which is frankly what we see the most common clinical presentations are with M.gen genitalium. The first is a case of an 18-year-old heterosexual male presenting with urethral discomfort and intermittent urethral discharge for about 1 week. He reports being in a new sexual relationship for about the last 6 weeks or so. On examination, we find that he has cloudy urethral discharge as shown in the representative photo there. And then per our standard practice, we do a urethral gram stain, which shows elevated PMNs or neutrophils per oil field, but no gram-negative diplococci suggesting gonorrhea. And so we would diagnose this male with non-gonococcal urethritis. And per standard practice, the question comes up, what STIs will we test him for? We're certainly going to test him per CDC guidelines for chlamydia, gonorrhea, and trichomonas. But would you treat him with this would you test him at this initial presentation for M.gen genitalium? I'll give you just a couple seconds to kind of think about this, whether you would go ahead and do an M.gen genitalium test or not at this time point. Okay, so there is kind of actually not really a correct answer here. If you're following CDC guidelines, then you would not do an M.gen genitalium test at this point, because this is the initial presentation of urethritis. And the CDC guidelines recommends the only test for M.gen genitalium in men with urethritis that's recurrent or persistent. However, I will tell you that there's already some clinical sites in the US that realize that it's more efficient for patient care if you test them for M.gen genitalium at that first visit, because that way, when they're done with the first week of doxy, you already know whether they're M.gen positive, whether they need that second treatment or not. And so I will say that, again, that it kind of depends on whether you ask people that are doing what they think is more efficient versus what CDC recommends. So in this case, this is in our clinic. We followed standard CDC guidelines. We did not test for M.gen genitalium at this first urethritis episode. We did treat him with doxycycline for 7 days for NGU and counseled him about the fact that this is an STI likely, that he needs to be abstinent until he's treated, until his partner is evaluated and treated as a contact urethritis. And then only come back if symptoms don't resolve or they recur. But if he tests positive for chlamydia, gonorrhea, or trick, we do want him to come back in 3 months for repeat testing, because the frequency of repeat chlamydia, gonorrhea, or trick is up to 20% at that 3-month time period. So what happened in this case was his chlamydia test was positive. His gonorrhea and trick test was negative. He finished the 7 days of doxycycline, but he comes back 2 weeks later after finishing treatment saying that he still has persisting urethral symptoms and discharge. And he reports being adherent with the 7 days of doxy and still being abstinent since he was tested. And so, chlamydia is easily cured with 7 days of doxycycline. So this suggests there's another process going on. And we do another exam and gram stain, and it shows NGU again. And so I'm thinking already this is Mycoplasma genitalium, because it's the most common cause of recurrent persistent urethritis, and he was adherent with his treatment and abstinence. So the question is, if you clinically now are suspecting M.gen genitalium, would you treat him? If so, which regimens would you treat him with? And I'll let you look through these for just a second, and then I'll kind of run through why there's really one best answer in this group here. Okay, so the best answer is answer C. The reason why azithromycin is not a good choice is because, we don't know if he has a macrolide resistance mutation. Dr. Munson showed you that the majority will be macrolide resistance, and most of those patients will fail treatment. So giving him a regimen that he's likely to fail doesn't make sense. You should treat him because at this point, he's symptomatic, you're suspecting M.gen genitalium, and he's failed the other treatment. And so it really comes down to B or C. And the reason why C is a better choice is it's been 2 weeks since he finished the previous regimen of doxycycline. You won't find this in the guidelines, but some experts, including myself in the field, suggest that if it's been more than 1 week since you finished the doxycycline, that's probably good practice to go ahead and repeat the doxycycline again before giving them oxyfloxacin, just because having been 2 weeks in this case, you've allowed the bacteria to start to grow back up again. And you really want to knock down that bacterial load with doxy before you give them the moxifloxacin to limit moxifloxacin mutations, resistance mutations developing. So the best answer is C. And that's what we did. However, after giving him the combined doxy, moxy, so sequential treatment, he comes back 2 weeks later with persisting symptoms still, has NGU again, still adherent with treatment and no sexual activity. And so this is becoming this, these people who are failing our first line and second line treatments, this is becoming a pretty frequent occurrence now. And when you see this, think about a multi-drug resistant isolate. So now he's failed doxycycline by itself, and he's failed doxycycline followed by moxifloxacin. Which of these treatment options do you think would be best to give this patient now? And I'll give you just a minute to look through these. All right, well, so the best choice is C. The best choice is minocycline C. Azithromycin is really not a great choice. Again, even though we don't know whether it's macrolide resistant or not, it likely is, especially the fact that it's likely quinolone resistant because he failed moxifloxacin. Most of the quinolone resistant strains are also macrolide resistant. And so I wouldn't use azithromycin. I wouldn't give moxifloxacin again, even though it's a longer regimen, because he likely failed because he has a moxi-resistant strain. Tinidazole, which we'll talk about, is in the nitramidazole family like metronidazole or flagyl, but there's no published clinical efficacy data. So we don't really know how well it works, even though in the laboratory in culture, it looks like it might work pretty good. Minocycline, on the other hand, there's been some case reports and one observational study suggesting that over 70% of patients who you give 14 days of minocycline will be cured. And that's our experience as well in using this drug in patients who have failed kind of these first-line regimens. And so again, minocycline, it's been around for decades now, so it's a very old antibiotic, but does have some published efficacy data curing over 70% of these patients. Amaticycline is one of the newest tetracyclines on the market. It actually, in vitro in culture, has the best activity against M. genitalium. However, there's no published clinical efficacy data, which would lead me to not want to use it first. I would first try minocycline. It's also very expensive, over $2,000 out of pocket for a 7-day treatment course. Another reason I think not to use it in most of our patients. But it is out there, something to think about if somebody were to fail minocycline. Tinidazole, as I mentioned, in vitro in culture, looks like it should work well against Mycoplasma genitalium, but simply no published clinical efficacy data. I have used it in a handful of patients who have failed other treatments. Only one has been clinically or has been microbiologically cured that we've tried it in. But again, it's one possible salvage regimen that you could use. And then there was an antibiotic called lefamulin that we were trying. It wasn't working very well, but we were trying it. But now it's not currently available. The company that made it is no longer making it. And so I don't think that you can get it anymore at this point. And I don't know if another company is going to start making it or not. So minocycline is really your best treatment if you fail doxy and moxifloxacin, and that's what I would go to first. Let's wrap up with another really quick case. This is probably one of the most common consults that we get for M. genitalium in our training center. 19-year-old pregnant female who's at about 13 weeks gestation, comes for her first prenatal visit. She reports having vaginal intercourse with a single male partner for the last 12 months, not using condoms, and that's because they were trying to get pregnant. She denies any urogenital or pelvic symptoms, and her genital exam is normal. Her OB provider says, I'm going to do the routine STI testing today on you. That's per standard of care. Dr. Munson didn't get into this, but the diagnostic tests that include chlamydia and gonorrhea and trick often also include M. genitalium as part of those tests. Because this is an asymptomatic patient, CDC does not recommend screening this patient for M. genitalium. But if you choose one of those diagnostic tests that includes M. genitalium on an asymptomatic patient, you're going to get a test result. And then you have to decide what you're going to do about that test result in the asymptomatic patient. And so that's exactly what happened in this case. And we get a lot of these cases right now where OB providers are basically doing these tests that include M. genitalium, and they're coming back negative for the usual STIs, chlamydia, Neisseria, and trick, but they're coming back M. gent positive like this case. And so this test should never have been done in this pregnant female who's asymptomatic, but now you have an M. gent result that's positive. So the question is, are you going to treat this positive M. genitalium result in an asymptomatic pregnant female? I don't know what the right answer is for this. I think there's an argument, yes, because it's sexually transmitted, right? And so if these individuals are having sex with others, they can transmit it to them. But on the flip side, we don't know if an asymptomatic infection will cause any harm in this patient, but you giving antibiotics could potentially affect the mother, less likely the baby, I would say in this case, but potentially the mother. And also, just by you treating this patient, you're telling them that you think it's important enough to treat, and they're going to want to ask you, is it cleared or not with this treatment? And which means you're going to want to test them again. And if it's still there and you can't get rid of it, now you have, in this case, a pregnant female who's worried sick that she has this STI that can't be cleared, but she has no symptoms or clinical consequences at the current time. So that's the argument for maybe why you wouldn't treat a positive M. genitalium test result that you should never have had in the first place. So the way that, just briefly, as far as M. genitalium treatment of pregnancy, macrolides is the only antibiotic we have in the US that has published data saying that it's safe and effective to use for treating M. genitalium in pregnancy. So tetracyclines, quinolones, and the famulin are not considered safe in pregnancy. Only azithromycin in terms of the antibiotics we have in the US. The nitroimidazoles like tinidazole are probably safe in pregnant women, but again, we don't know how well they actually work against M. genitalium. There is an antibiotic which you cannot get in the US. It's in select countries outside the US. It's made in France. It's called pristinamycin. It is safe in pregnancy, and it works pretty well against M. genitalium. But for you to get it imported into the US to treat a pregnant female is going to be really complicated. You have to actually have FDA approval and IRB approval, consent, etc. I've done this for another patient who was immunocompromised one time. And it's just not something you're going to do in most of your patients here in the US. My point here is that you should not be doing M. genitalium testing in pregnant women unless they have a clear-cut CDC recommended indication. So think about which tests you're using to screen STIs in pregnant women. But what was done in this case was there was a shared decision-making approach where basically the patient and provider had a discussion about potential benefits or risks for treating M. genitalium in pregnancy with azithromycin. This patient wanted treatment, and so she was given the extended azithromycin regimen, no doxy, just 1 gram of azithro day 1, followed by 500 milligrams days 2 through 4. Even though it's not recommended to get a test of cure, and this patient had no signs or symptoms, the provider got a test of cure 4 weeks after the azithromycin treatment anyway, and it was still positive, which is not surprising because the majority of strains will be macrolide resistant, and most of those patients will fail macrolides. And so now what do you do? There really is no other treatment in the US that you can give this patient. Giving longer azithromycin is not going to lead to a better outcome. And so what was done in this case was they just observed the patient during pregnancy. She had a normal term delivery. And then after she delivered, she was treated with doxycycline for 7 days, followed by moxifloxacin for 7 days. So this is really more of an educational consult because we get this consult so often. So I'm going to just end here by saying that a quick summary of some of the key points from our talk, from mine and Dr. Munson's talk, was that M. genitalium is an infection which may be asymptomatic, but can also cause clinical manifestations such as urethritis, cervicitis, possibly PID. This infection is highly prevalent, as Dr. Munson showed you the data, in clinic-based settings, and that the NAT test is what's recommended for M. genitalium detection if you're testing at urogenital site, vaginal swabs in women, first catch urine in men. CDC recommendations for who you should test for M. genitalium is men with recurrent persistent urethritis, women with recurrent persistent cervicitis, and women with PID. And then we just talked about how challenging M-gen treatment can be due to drug-resistant strains, and that the majority of strains are macrolide resistant. Quinolone resistance is also emerging. So now we're having to use salvage drug regimens like minocycline for 14 days. But you really need to be judicious in who you test for M. genitalium, and really, especially not test patients who are asymptomatic at this time. So Dr. Munson and I both thank you so much for attending the webinar. We're going to take the next 5 or so minutes for questions you may have. Here's our email addresses if you have additional questions, and Kate will also get those questions to us. Thank you.
Thank you all so much. Before we start to roll in the questions, we have about 4 minutes and I want to be respectful of everyone's time. So really quickly, just a couple reminders. This recording will be shared through the LMS platform, so you'll be able to access this afterwards. And we'll also take those questions that we didn't have time for, and Dr. Munson and Dr. Geisler have offered to answer those questions offline, and we will send them all out to all the registrants. So we'll be able to answer everyone regardless. So again, go ahead and go to those emails if you do have additional questions that we won't get to. And then Hologic does have a doc matter community specifically discussing M.gen that you are welcome to join. I put up the QR code here, so that's another opportunity to ask additional questions and have conversation there. So we will roll into the questions. I'm gonna go ahead and get to one that has been asked twice. Someone did direct message me, and then I saw someone sent the question again in the chat. So let me just roll to it here.
Hey, Kate, given the
Yeah,
time with only a few minutes, I can do rapid fire with a lot of these if you want. I
you
think we can get
go
through
off
them.
then.
If you let
Yes,
me go, and then Dr. Munson can chime in too if he wants to. But
absolutely.
when babies are born to a mother with M.gen genitalium, we know that you can detect the bacteria in the eyes of the baby. We don't yet know whether it causes clinical disease in the eyes or pneumonia. Chlamydia certainly causes conjunctivitis in a baby born to a mother vaginally, as well as pneumonia, but we don't really know with M.gen genitalium. So I think that's to be determined. We simply just don't know, but we know you can find it in the baby's eyes. You ask why not treat initially with minocycline? You could use minocycline instead of doxycycline. It's got a little bit better activity in vitro than doxycycline. The reason why we don't typically do that is that minocycline has more side effects than doxycycline. Particularly dizziness is way more prominent with minocycline than doxycycline. But if you had a patient that you were concerned, like maybe they'd already failed an initial regimen and now you're in the salvage regimen, you could use minocycline instead of doxycycline for the first 7 days if you're using some other drug besides minocycline. So that is an option, but it just dizziness, even in young people, is quite common, and some don't tolerate it, and that's why we just don't use it in everybody. Scrolling through the questions, let's see. There was the one about what do you do if you can't test the partner? Should you just empirically treat them anyway? I would say that, yeah, I think if they had unprotected sex, you're concerned about a partner, you don't have a test for a partner, particularly who's at high risk, I would probably err on the side of treating them. But I will say, and Dr. Munson can chime in on this point, pretty much almost every major urban city in the US now has an M.gen genitalium test in their commercial labs. So if you go to like the LabCorp and the Quest, they have a test. And whether your doctor knows it or provider knows it or not, they still have those tests. And so I think a lot of people don't realize that, but you can probably get these tests. Do you want to chime in on that, Dr. Munson?
I'd be happy to. Yeah. It may not be a local laboratory, but like Dr. Geisler said, some of the national reference laboratories like LabCorp and so forth, they do have it on board. So I think a lot of it is an educational matter to the providers to know that those options are available, because we had gone for decades and decades with, relying on a slow turnaround time test. So yes, those options are available. Can I just add to the one comment that Dr. Geisler made during his thing about test to cure?
Yeah.
So I agree with what Dr. Geisler said. And what a lot of providers don't know is that not all amplification methods are created equally. There are some amplification methods, such as RNA amplification, that are more analytically sensitive than DNA amplification methods. So for that reason, I'm not a huge fan of test to cure, but if you had to do it, I would wait at least 3 weeks, because your assay that you're using for test to cure may be a very, very highly sensitive assay like RNA, and you don't want to run into that possibility of picking up nucleic acid from dead organisms or treated organisms.
Kate, maybe 2 quick responses I can do really quickly. The question about doxy-pep prep, will that impact M.gen resistance? So we have 2 different patients right now in Birmingham that we've identified tetracycline-resistant strains, where they were treated with multiple courses of doxycycline, and their tetracycline MICs increased during this treatment. Neither of those strains were doxycycline resistant, but the MICs were higher. So we do think that repeated courses of doxycycline will lead to strains having higher MICs, which means if you try to use doxy to lower the bacterial load, and now it has a higher MIC, it may not work in that role, and patients may be more likely to fail treatment to either doxy or the subsequent treatments like azithromycin or moxifloxacin. So yes, there's a concern, but we don't really have any large-scale data to that. Did you want to, Dr. Munson, or any other comment about that one?
No, I agree with your assessment, absolutely.
Yeah, I think there was only one more question about the asymptomatic transmission. We know that if you look at concordance amongst couples, we do know that you can find concordance of M. genitalium in those who are asymptomatic. So there is some asymptomatic transmission, but we have no idea how efficient it is. I mean, typically, like most organisms, you would think with a higher bacterial load, there would probably be greater efficiency of transmission. And, if you have signs or symptoms of infection, typically with most bacteria, you probably have a higher bacterial load. But we really don't have that data that I'm aware of. Dr. Munson can chime in to show that it's, how transmissible asymptomatic infection is.
Yeah, I think there is literature out there to suggest that, for example, chlamydia loads might be higher in folks than M. genitalium loads. So I think that further supports that notion as well.
Great. So I think that's all we have time for questions-wise, but Dr. Munson, I always happen to answer any additional questions you fire our way by email.
Yeah, thank you so much, everyone, for joining. Like I said, we'll be sending out just sort of a summary, and you'll be able to access that recording. Please do keep an eye out. We'll be promoting the upcoming second part in this series on vaginitis. So we'll be releasing that shortly, and that'll be this summer. So I appreciate you all for being here. And thank you again to Dr. Geisler and Dr. Munson for that wonderful presentation. I hope everyone has a great day.
Awesome. Thanks, everyone. Have a good day.
Take care,
Thank
all.
you.